Thank you very much for the introduction and for the invitation to talk about this important vessel and should I say the third ventricle, not in the brain, but in the thorax. What about the imaging targets? So basically we need to look at structure and morphology. Geometry obviously is very important, so global morphology, but also the wall structure itself, and maybe the biology, maybe that's the last frontier, but also function with both deformation and flow. And so obviously MRI, I think everybody here is convinced that we can do the dynamics of the wall with very high precision. Also, of course, in coupling with the heart, we can do, of course, look at the wall, and maybe that's the most difficult because of partial volume effects. Angiography evidently is also of extremely high quality now and very short acquisition times. And flow mapping, here a nice image from Dr. Markle's group showing a ventral aorta, of course, is coming into practice. There are challenges, though. Spatial and temporal resolution remain an issue, although we can work at 0.7 millimeters isotropic, and we can also reach less than 10 milliseconds of temporal resolution. Jet visualization for the valve is also sequence dependent, and there's a relative underestimation of maximal velocities, as we'll see, and we still have to average cardiac cycles. Nevertheless, there's an increase in the use of MRI, overall cardiovascular MRI, and basically the aorta accounts for between 5 and 10% of those acquisitions, and this is increasing. When we look at what we can actually do, here are images and routine images acquired of patients for the full aorta. The full coverage is something that is really extremely interesting here in volume rendering and also time resolved acquisitions. This has huge advantages, of course, of being 3D. This is a very good, a very important feature. Obviously, a disadvantage is the use of contrast and the issues. I won't go too much into detail about this. Non-contrast MRA is also extremely useful, and on daily routine practice, we tend to use more and more these SSFP sequences. You can see very nicely here the coronary arteries on this volume rendering. Very interesting before aortic root surgery. Also here a central aortic regurgitation. So the quality of the anatomy that we can get, both 3D, in-plane, MPR, VR, is of very high quality. Aortic wall analysis obviously is a problem. You know that the wall is about 2 millimeters thick, and so some of the results from large studies, like these were the GE data was analyzed by Ashkan Malayeri years ago in the MESA study, and then we went with Evrim. We looked at the larger sample with all the sites, and of course, you know, you really do have the issues. Those are older images of partial volume effects, and so the relationship with risk factors was quite variable. Now, new techniques have been proposed to look at high resolution 3D black blood navigator gated the wall imaging, and so this is quite interesting. Of course, we need in the ascending aorta to have gating, and I hope the sequences that we showed this morning, the 5D will be extremely interesting in this area. And coming to the wall characterization, of course, maybe the T1 and T2 mapping techniques would be interesting. I say would because obviously in very thickened diseases, as we will see, maybe that can be interesting, but with only 2 millimeters, there's huge partial volume effect. In everyday practice, of course, phase contrast, even 2D, plays a role in most centers. It has to, of course, the problem here is you have a multiplane acquisition, and this is a problem, of course, if you have problems with jet orientation. It can be of high resolution, very high, both spatial and temporal resolution. Below 10 milliseconds is possible with acceleration and the views per segment properly set. And, of course, one of the main challenges remains with the proper segmentation, of course, VENC issues, and also phase offset that now are widely available in terms of the software is usable. So in everyday routine, we quantify shunts, we quantify regurgitant valvular regurgitation, and also valvular stenosis, but also diastolic function. This is an example from our group. Just as with the echo Doppler, you can measure with very high reproducibility the transmitral flow and the basal left ventricular velocities. Now, not going into detail, just to remind you that we have to be very careful in daily routine when comparing to echo, which measures a a maximal velocity, here 4 meters per second in the aortic stenosis, not to be mistaken for the peak mean velocity that for which we have a very high reproducibility with MR, much less with the maximal velocities because of noise issues. They are close, but it's important to be very careful about these issues. Of course, VENC setting is also extremely important to be just over the maximal velocity that we are encoding. With this example here, this is with Vmax was 3.5, and so actually with properly set VENC, we could get a pressure gradient estimation extremely close to echo with a PEDOF in this case. And of course, and a large, oops, that was unexpected. Something wrong with the 4D flows, too many images. I hope this is, sorry about that. And so, of course, and largely thanks to Dr. Markle's group, 4D flow has been put forward very much so. Here an example of an interatrial shunt in one of our patients. Of course, in congenital disease, it is a prime use, of course, of these techniques in follow-up in TGA, in septal defects, obviously in valvular disease also, and we're coming to this. But also in aortic disease, it has some very interesting applications, and also in other arterial territories. So now the first application in everyday routine is the aortic aneurysm. You know, the prevalence is underestimated. It is 60% actually of thoracic aorta aneurysms also concern the abdominal aorta to some degree. And of course, we all know that the cumulative degree of rupture is based on the diameter. Now, this is a very frightening, I think, diagram showing that half of the people who actually have aortic dissection in the IRAD registry have it below the threshold for surgery. And I think this is a disaster, basically doing what we're doing, but this is the guidelines, only basing our decisions on the diameter. So what should we do as of now? So it is extremely important to measure this diameter. Nevertheless, the first step is to detect thoracic aortic aneurysm. It's often infraclinical, so we have to detect that. And this is itself very important because it will lead to medical treatment, and this is often forgotten. But control blood pressure, discuss some other things, stop smoking, of course, discuss statins, physical activity, and so on. So that's important. Then there's the question of follow-up. If the aneurysm is below 45, it's annual imaging. If it's in between 45 and 55, it's going to be semi-annual imaging. And then going on to elective aortic replacement, and I won't go into the precise indications that you all know, but what is very important is to be very precise in this diameter measurement. So now in MRI, in CT, we had those nomograms. Now in MRI, we also have a lot of data for both men, women. According to BSA, we know that the growth, normal growth of the thoracic aorta, the ascending, is 1 millimeter per decade approximately. So this is very important. And we also have those interesting approaches with risk tables, with both size and according to the BSA, you basically have, like in coronary artery disease, the same approach. And this is also very useful. Now, this is an everyday example of what's happening. So I took all of these MRAs from this patient who was followed from 2006 to 2013, and I got all of the reports. And every report was stable, as you know, last year. Stable, stable, stable. So now in 2013, we are at 58 millimeters. Or 55, millimeters, and this is slowly growing. This is everyday, practice. Always have to go back to the earlier imaging method and have two things in mind. First, be very careful of the slow progression of this disease because this patient could have been going on, and finally was operated. At this point, it was a tricuspid patient. First thing. Second thing, to bear in mind the variability of the measurement that we have. It's 2 millimeter thick in the wall itself, so be very careful if you're measuring the outer border or the inner border, and it's probably much more reliable to measure the lumen itself in the absence, of course, of thrombus. Now this was the 3D contrast-enhanced MRI. You can do this with 3D SSFP of the thoracic aorta, have a very nice depiction of the annulus and also of the root of the sinus of Valsalva, and have very fine measurements of these at this point. I won't go into the details of the measurements here. And we will all, of course, do a report according to the landmarks in the aorta that are consensual, the US and Europe, and do MPR analysis. This is an MPR starting with the annulus and going on upwards to the junction and so on, and have very good reconstruction parallel to the vessel wall. Now that's an example of a comprehensive MRI assessment for a bicuspid valve patient here who had aortic stenosis. You can see that there's also aortic regurgitation to some degree. It's a type 0 here, you can see very well the opening here of the valve, so it's not a very severe aortic stenosis, and of course the ventricular effects of this stenosis here. Now we've talked about diameter, but length was also shown to be an additional predictor of aortic dissection, and this is something very important because we have to very precisely measure aortic length. And so maybe going further than length and diameter, which is an integrator of both, which is going to be volume. And these are images from Thomas Dittenbeck in the our LIB team, showing the possibility here in a fully automated method to measure segmental volumes. And you can see here in different groups how these will evolve. And what it was very interesting here is the ability, and Nadia Kashinora showed this morning, for volume to be able to distinguish the small changes in the hypertensive groups, but also have less variability in the aneurysm groups compared to diameters. What about acute aortic syndrome? I don't know about you in your hospitals. In our hospital, we always go for CT. In these, those are older statistics now, showing that most centers use CT, of course, in that context. However, in the chronic phase, it can be very interesting. Here also a paper from Northwestern showing the ability of 4D flow to show us the entries across the flap in these patients. Here is an example in our center of 3D flow showing very nicely here how the flow is going to be organized in this entry, and we're doing a study right now looking at what will happen if we put here an endograft. And so endograft follow-up is also probably very interesting to place it according to the flow itself and not only the anatomy, and then to do the follow-up. So those are probably very interesting things in the future. This is a 43-year-old male who had hypertension with pentatherapy and had to wait until this age to actually, with this hypertrophy, to be identified as having a native coarctation. This is another example of a 52-year-old male who had aortic valve replacement and had two questions asked. He also had coarctation repair. So two questions: how's the coarctation doing, and how is the valve doing? And so this is also, I think, a very interesting application for 4D flow, where we can be directly perpendicular to the highest velocity here in the coarctation. On one side here also assess the valve, and for example, in this patient, there was no aortic regurgitation, no significant aortic regurgitation. Aortic sizing and arch morphology was assessed, and the residual coarctation was only 20%, with a low Vmax and a low gradient. So that was okay in this patient. Now for aortic valve stenosis, the aortic valve is actually segment 0 of the thoracic aorta. Of course, we can assess velocity and flow at rest and valve anatomy, and also LV function. We don't know about the role of low-dose dobutamine MRI in this particular setting, but indeed, MRI is not the first-line modality, of course. Doppler is, of course, the first-line modality, but in some cases, it can be very interesting in complex cases to use MRI. Two approaches: planimetry and maximal velocity with high-resolution cine SSFP or phase contrast modulus. And also the continuity equation can be used in order to assess the severity of the valve. This was an example of a TAVI planning in one of these patients with aortic stenosis. Am I running out of time? Yes, I have to conclude. Okay. So I'll go on to a conclusion here showing this, how this could be successful. just to show you this example here, postoperative status here in this patient. This is 3D CE MRA. You see blurring here. Very nice here acquisition using the 3D SSFP. So in this context, it's highly usable. And ending on this, in inflammatory disease, you can do black blood pre and post GAD acquisition here to look at this thickened wall in Takayasu disease, stenosis in sine, and also, of course, access all of the different vascular access in this patient. So I will conclude on these images showing the very important role of MRA in the thoracic aorta. It's very difficult to assess completely, if not impossible, by echo. And of course, it's a non-invasive method of choice to follow up patients, even after surgery. Thank you.